Good evening, this is Adam again, and today I am going to be covering Pharmacology 2, Exam 1 Review. Obviously, I am playing around with PowerPoint themes today, so this is why it looks a little different. So as it stands, it is approximately 8:30 on Thursday night, and Wednesday night, and I have received 0 questions about the exam. This leads me to believe one of two things. Either I am such a masterful teacher of pharmacology that you guys have absolutely 0 questions because you've simply integrated the knowledge so well that you have no questions, or you may have another test or something better to do than to study pharmacology at this time. I'm going to assume it's the first, but just in case there are one or two of you that have not gotten everything down, I will cover couple of things that I think are important. Obviously, this will not be a completely exhaustive review of all the material for the test, but just a few kind of key points that stuck out in my mind that I think you guys should at least be somewhat familiar with. So we'll start out with the PEDS section. Obviously, we had 3 lectures on that. Again, I tried to make the test pretty representative of the material that we covered, so I tried to make it relatively even. Obviously, there's going to be a little bit of difference there, but I tried to make it somewhat even. So when studying, I would give each section probably equal attention. Obviously, the first PED section was a little bit of a review, but certainly things that I thought were pretty important to have a firm grasp on. So one of the big things there being the pharmacokinetic differences that are inherent to dealing with pediatric patients. So obviously there are very different than adults. You may have mistakenly believed that children are just tiny adults. Certainly not the case. Obviously they're different in pretty much every way, including things like absorption of drugs. So especially kids when they're very young stages in the kind of the neonatal period, especially how their absorption is going to change. Especially for things like basic medications or acidic medications, because their GI tract may not actually be producing acids at a certain point. Or potentially their GI tract has been full of amniotic fluid, which is relatively basic compared to normal GI tract secretions. Obviously, it's going to be affecting the ionization of certain drugs, so they may or may not have a harder time being absorbed into the body. So obviously, things that are more basic would be dissolved better in more basic solutions, so those have an easier time getting absorbed, whereas things like more acidic medications, weak acids, would have a harder time being absorbed in those more basic solutions, just due to the fact that they're in a higher ionized state and have a harder time crossing those biologic membranes. Distribution obviously is going to be different between adults and children as well. As you remember, I kind of likened kids to big bags of water, especially the younger they are, the more that holds true. So because they're total body water has a higher percentage compared to adults based on their size. Things like hydrophilic medications are going to have a larger volume of distribution just because there's more water for the drug to partition out into. And so obviously your blood levels are going to drop down in those cases, so the drugs will have a higher apparent volume of distribution. You'll remember with our aminoglycosides how those are pretty water-soluble medications, and they required larger doses in the infants and neonates due to that fact. So in order to achieve the same blood levels as an adult would have a lower volume distribution, you need higher doses in children. So that's where you can see doses of 4 or 5 milligrams per kilogram in order to achieve therapeutic blood concentrations versus an adult maybe only 2.5 milligrams per kilogram. So obviously volume distribution will be much different. Metabolism is going to be a big change too. So obviously the younger they are, the less developed many of their metabolic pathways are. Obviously there's some exceptions to that, things like sulfation happens to be pretty good from birth onwards until it kind of drops back down to a normal adult level. But a lot of things like your CYP enzymes are not going to be nearly as effective. Things like glucuronidation, different pathways are not going to be well developed. So for drugs that are highly dependent on hepatic metabolism, you may see that they need smaller doses or maybe given less frequently, since they are unable to metabolize those not quite as quickly as an adult might. With excretion, obviously the more immature the child is when they're born, and I'm not necessarily referring to their behavior, but more or less to their developmental maturity. Obviously, children that are born premature, say, born at 28 weeks or 32 weeks, somewhere in the mature area, or immature area, their kidneys are not going to be nearly as well developed. The renal tubules simply are not all there fully developed, so their excretion of drugs is going to be less. So potentially, again, for drugs that are renally eliminated, so again, going back to our aminoglycoside example, we will often see that dosing is based often on postnatal age. If you guys remember, that postnatal age is going to be the gestational age plus the actual time that they've been born. And so essentially what you're seeing there is that the younger they are, the more underdeveloped the kidneys are, the harder time they're going to have to be excreting those medications. So say for instance for gentamicin, you may see a child born, say less than 28 weeks, would receive the drug every 48 hours, versus a child who's born at term would be, say, every 24 hours, just because the kidneys are not really there functionally in order to eliminate the drug at a good solid rate. The other thing to take into account when dealing with PEDS is obviously our drug dosing calculations. Now, I did put a few questions there on the test. Nothing too significant to be worried about, but certainly something you want to be aware of and know how to do. I did not make the math difficult. Most everything can be done in your head or with a quick pencil and paper kind of calculation, but some of the sticking points that I want you to be aware of, again, are really analyze the question prior to jotting down an answer. Be aware of what I'm actually looking for, because it's all well and good to say, let's dose this kid amoxicillin 50 milligrams per kilogram once daily for 10 days. That's all well and good, but at the end of the day, the parents are the ones who have to actually measure out the dose and figure out how to give it. So it's important to know the actual total dose that you're giving the child, and also the volume that's going to be based on the concentration of the drug. Especially with PEDS, you're going to see that a lot of times we're dealing with suspensions and solutions and liquid preparations, just due to the fact they have a harder time doing things like swallowing medications. And so due to that, it's really important to make sure that the volume that the parent's going to be administering is readily apparent to them. Again, we don't use teaspoons or tablespoons, because depending on who you talk to and what type of spoon they're using, that can vary quite greatly. So again, be pretty analytical on those questions. Look at exactly what we're asking, based on the child's weight, how much drug should they be getting. So if I say a child's getting, a 10 kilogram child is getting 50 milligrams per kilogram per day, obviously multiply that out and figure out what I'm asking from there. So whether or not it's, how much does the child receive per dose, or how much volume do they receive per day. Those are the little things you want to keep an eye on, because that will certainly change how your answer is going to look at the end of the day. So again, refer back to the practice questions I had on the first PEDS lecture, and I think you'll find that they are pretty representative of the kind of questions that will show up on the test. Going into the next PEDS lecture, obviously we want to take a look at things like our pregnancy categories. What are the differences between a category B drug versus a category D drug? Obviously, a lot of it has to do with how much literature there is to support a drug's use, whether it be that we have animal data to support or to refute toxicity, or if we have human data to do so. Kind of getting a good idea of what those differences mean are pretty important. Obviously, the FDA is moving away from most drugs having these very delineated pregnancy categories, because again, so many of them got category C that it wasn't clinically very useful to you guys. But at least be aware of the ones that do have pregnancy category, what that means. Obviously, things that are category A or B are pretty good to go for pregnant women, but keep in mind what the differences between things like a C and a D and an X rated drug. Looking at placental or breast milk transfer of medications, obviously be aware of the physiochemical properties of drugs that will affect that. So things like the size of the molecule, the pH of the breast milk versus the serum, and the ionization state of the drug, whether it's a weak acid or base. The same things that we've talked about previously in pharmacodynamics, things like Fick's law, hold true here as well. Obviously, there's some other factors that can play a role. There is placental metabolism of drugs that occur, and there are active and passive transporters that happen, with breast milk transfer and things like that. But at least be aware of the major components of a drug and how that can affect the absorption of it. Looking at the different pregnancy kind of comorbidities that can pop up during pregnancy, I would certainly keep in mind the drugs of choice for the different conditions. So say, for instance, we wanted to treat a patient for significant nausea and vomiting during pregnancy, be aware what we would go to as a first choice or as a second choice. Things like gestational diabetes or intrapartum depression and things like that. Just be aware of what type of therapies are available and what are kind of the go-to drugs in a lot of those cases. And then we talked a little bit about some of the neonatal conditions, so things like sepsis and herpes and things like that. Obviously, be aware of the drugs that are going to be used most often. Obviously, they're going to be geared towards certain organisms, especially on the antibiotic side. Be aware of what those organisms may be, especially between things like late and early sepsis. Obviously, the bugs change a little bit based on the age of the child. And then also, specific drugs that we talked about for different conditions like respiratory distress syndrome. We talked a little bit about surfactant and how that's administered in the children, and how that's somewhat unique. And also necrotizing enterocolitis. We talked about that as well. On the third PEDS lecture, we talked a little bit about CF, and I know it's something you guys may or may not have had a lot of exposure to previously, but obviously if you work in a PEDS setting, you may or may not run into it with some frequency. Obviously, CF affects a lot of major exocrine organs, lungs being primarily affected, the GI tract being affected. Just be aware of the different conditions that pop up due to the disease state and some of the medications that we're going to use in order to combat that. So things like, the bile duct getting clogged up with a lot of the cholesterol and the bile salts due to issues with pancreatic function. Obviously we're going to use things like ursodiol in order to help clear that up a little bit to prevent things like biliary stones. Be aware of things such as antibiotic selection, looking at things like the fact that these patients are more likely to have resistant bugs like Pseudomonas and Burkholderia and things like that, and what type of antibiotics we might use for those patients that we may not use off the bat for typical type pneumonia patient. Also, we talked a little bit about Orkambi, or Orkambi, however you want to pronounce it, the Lumacaftor and Ivacaftor. That's really the newest drug available for CF, so at least be a little bit familiar with that drug and how it operates. For the other conditions you might run into with some regularity in PEDS would be obviously GERD and constipation. We'll certainly talk about these drugs again when we get to the GI section, but just be aware of what some of your drug options are, how some of those mechanisms work, drug interactions, and certain things that may or may not be contraindicated in PEDS specifically. So especially like in the really young kids, like there are certain constipation regimens that are not really recommended due to things like electrolyte changes, those being mainly your sodium phosphate enemas and things like that. You want to be aware of. So not necessarily know the ins and out of every single medication, but know some of the differences between the PEDS or the PEDS kind of idiosyncrasies that you'll see here. Moving into our rheumatology section, obviously we covered rheumatoid arthritis and also osteoarthritis. I would definitely be aware of some of the differences in treatment modalities between the two. So say for instance with rheumatoid arthritis, obviously you're focusing much more on the inflammation side of things, versus with osteoarthritis you're dealing more with kind of like the mechanical irritation that's happening there. So obviously medications are going to differ pretty widely between the two. So for instance, things like NSAIDs are going to be used a little bit differently between OA and RA. Obviously because the NSAIDs are going to be focusing much more on inflammation. They're going to be one of the cornerstones of therapy of rheumatoid arthritis, whereas with osteoarthritis, mainly going to be relegated more towards flare-ups and exacerbations. Again, a lot of that goes back to a lot of the toxicity you can see with things like NSAIDs, where GI toxicity being one of the primary issues. Certainly, the kidneys can take a hit as well, especially if the patient has some degree of renal insufficiency. But because of that, that's why things like Tylenol are going to be much more important in their regimens for osteoarthritis, as opposed to an RA. They're not really, Tylenol is not really going to be all that effective, and so it's not really ever used. But NSAIDs certainly will be one of those daily medications that they take. The big new group of medications we talked about here were the DMARDs, or the disease-modifying anti-rheumatic drugs. Obviously, be aware of their mechanism. That's going to be really important. Obviously, you have your biologic and your non-biologics. Your non-biologics obviously being a lot more or at least a lot less specific for how they're affecting. They're going to be affecting a lot more system wide. They're going to be affecting the immune system more systemically than you would see with something like one of the biologic DMARDs. But certainly be aware of the mechanisms of action, especially your biologic ones, because that's so important to how they're operating. So whether or not they target interleukin 1 versus 6, or TNF alpha, or they deplete beta cells and things like that. Those are the things you want to be aware of as far as the mechanism goes. Obviously, be aware of adverse effects. Things like black box warnings are all going to be important for those. So especially things like monitoring for TB and your patient is getting a biologic DMARD, or being aware that things like hepatotoxicity is really important for methotrexate, and what you can use as an alternative. And to go along with that, kind of their place in therapy. So like what kind of combination regimens make sense versus which ones don't. Obviously using starting off with a non-biologic DMARD. If they fail therapy with that, sometimes adding on a biologic one, or having multiple non-biologics. Obviously, having two biologics on at the same time doesn't really make a whole lot of sense from a therapeutic standpoint. And again, just kind of keep those little differences in mind between the different agents. With the behavioral section, obviously we talked a lot about a lot of different medications. So some of the stuff you have here under the antidepressant classes will pretty much be, generalizable to a lot of the other agents or other classes of drugs, in order to things to be on the lookout for. So obviously, one of the big difficulties is trying to internalize all these different drug names and being able to compartmentalize what category they fall into. So being able to recognize the difference between an SNRI versus an SSRI versus an MAOI versus a TCA. Obviously, it gets to be a little bit alphabet soup, but certainly I believe by compartmentalizing them based on differences in things like their mechanism are going to be super important for kind of helping you to determine what type of drugs you're dealing with, say for test questions. So obviously their mechanism is going to be much different. Most of the names just have it right there. So whether it be an SSRI or a MAOI, obviously the mechanism is right there in the name. Obviously these are not the main mechanisms by which they are fixing things like depression, but they certainly help us to know what type of toxicity you're going to see. So be aware of the differences in toxicity from a monoamine oxidase inhibitor that you would have versus a serotonin norepinephrine reuptake inhibitor. Be aware of those differences. Also be aware of the drug interactions, so especially things like with the monoamine oxidase inhibitors. Be aware of things like the drug interactions with tyramine containing foods and things like that, and how that can affect the patient. We talked a little bit about serotonin syndrome and serotonin toxicity that you can see with many of these agents. And just keep in mind the difference between that versus neuroleptic malignant syndrome. That was something we talked about with our antipsychotics. And oftentimes they can look very similar, but just be aware of some little differences that we kind of covered in class between the two. And obviously know what drugs can be causative or can lead to experiencing either one of these conditions. And then I know we don't talk a lot about herbal supplements, but St. John's wort is one of particular note, just in the fact that it can be useful for patients' depression, but it also, due to its CYP induction effects, can have wreak all kinds of havoc on other medications that are metabolized by CYP3A4. So certainly be familiar with that. Going back to bipolar disorder, again, we talked a lot about new drugs. Some of them, especially the anti-epileptics, we're going to cover more in the neurology section. But you should at least be aware of their mechanisms, or at least how they're going to be, what was presented in the lecture is obviously going to be the things that are going to be tested on. So I guess mechanism-wise, we're going to talk a lot more about that during the neurology section, since that's going to be more germane to that discussion. But certainly be aware of things like the drug interactions we talked about, or adverse reactions that you can see. So especially things like lithium, or things like carbamazepine and valproic acid. Be kind of familiar with those. Again, drug levels, we did mention those during the lectures, so those could potentially be on the test, so at least be familiar with what a therapeutic range would be for these different drugs. And then getting into schizophrenia, be aware of the differences in mechanism of action between your first generation antipsychotics versus your second generation agents. Obviously, those are going to have a lot of difference there between not only how they work for schizophrenia, especially concerning things like the negative versus the positive symptoms, but certainly in the type of adverse effects that they're going to have. So be aware of which ones are more likely to cause extrapyramidal side effects, or which ones are more likely to cause tardive dyskinesia, which ones cause more weight gain. Be aware of those kind of differences between the two. And then for those different adverse effects related to antipsychotic use, at least be aware of how to treat those. So if I have a patient who's having an acute dystonia, what might be a good option for them versus what might actually make their condition worse. And then looking at anxiety, obviously look at the difference between the different drugs we're going to use. So you kind of mentioned not only the the benzodiazepines, which are kind of a good rescue medication, have very fast onset, but also look at things like more chronic management for anxiety, things like SSRIs, and being aware of their onset of action. We always obviously know that those are going to be pretty delayed compared to things like your benzodiazepines or your beta blockers. So be aware of the onset and be aware of kind of the different situations where one might be more appropriate than the other. Obviously, Xanax or alprazolam might be really good anti-anxiety medication, but perhaps if I need to go and speak in front of a bunch of people, giving me a sedative might not be a good option. Maybe a beta blocker might be better for that kind of situation. So just be aware of those differences. And then with the ADHD meds, obviously there's a couple different classes of therapies we can use. So we have the stimulants, which are those controlled substances. They're all kind of amphetamine derivatives. How those are going to be operating versus something like an alpha-2 agonist like clonidine or guanfacine are going to be working to treat the symptoms of attention deficit disorder. And obviously the adverse effects are going to kind of go along with those agents. Obviously something a stimulant might be causing adverse effect wise is going to be a lot different than something like a clonidine might. So just be kind of familiar with those kind of differences. So anyway, this is a fairly short section, but again, did not receive any questions from anyone so far, so I will try to answer any of those that come my way between now and the test on Monday. Obviously, the sooner you get them to me, the better off your chances are of getting that question answered. Again, anything at all, please email me at my Gmail account. That's definitely the better account to get me at. Again, that's adamwoodrx@gmail.com. You can always try the Nova one, but again, I don't check that one quite as frequently. If you have stuck around this long, I will give you a bonus. The answer to one of the questions is C. Anywho, again, let me know if you have any questions, and otherwise, I will see you guys on Monday.